Let's get started with the MCQs. The first one says, Wireloop lesions are often characteristic for which of the following types of lupus nephritis? Lupus nephritis is the renal glomerular lesions of SLE. They are classified from class 1 to class 6. There are 6 classes of lesions you find in lupus nephritis. One of the types is called as Wireloop lesions, which is a very favorite MCQ that is asked. Wireloop lesions. Wireloop lesions are seen in class 4 onwards. Class 4 onwards, you are going to find Wireloop lesions, which is called as diffuse proliferative. Now, this SLE, diabetes, amyloidosis, all these are secondary glomerulonephritis. The table which we discussed was all primary glomerulonephritis. Secondary, the first one is SLE. So, the answer here is diffuse proliferative glomerulonephritis, that is class 4. This classification is given by WHO, which divides the lupus nephritis into 6 classes. Class 1, there is no change. There is hardly any change. Minimal changes are seen in the microscopy, seen in less than 5% of cases. On immunofluorescence, you are going to find mesangial deposits. In primary, there was one type where we saw mesangial, which was that mesangial deposits we saw. Deposits in the mesangium, that was IgA nephropathy. IgA nephropathy, the deposits were in mesangium, okay, and it was IgA type. In all primary type, it was IgG, except FSGS where it was IgM, and IgA nephropathy where it was IgA. The name is self-explanatory, okay. Everywhere it was in the membrane, either subepithelial or subendothelial or intramembranous. Only in IgA it was in the mesangium. So, in SLE also the deposits are in mesangium, okay, mesangial deposits. Class 2 is proliferation is there in the mesangium. Here there is no change on light microscopy. Class 2 there is proliferation, slight increased cellularity in the mesangium with increased matrix. The protein deposition in the mesangium is increased. This is seen in 10 to 25% of patients, class 2 lesions. Mesangial expansion, mesangial hypercellularity, and immunofluorescence. Apart from mesangium, there will be deposits in the membrane also, subepithelial or subendothelial, class 2. So, it is called mesangioproliferative lupus nephritis. Class 3 is focal and class 4 is diffuse. Class 3 is focal lupus nephritis. This is seen in 20 to 35% of the patients. Majority presents with class 3 lesions. Class 3 is further divided. Class 3 is focal. Focal means less than 50% of the glomeruli in the entire biopsy are going to show you deposits. Less than 50%. Diffuse means more than 50%. We have taken 50% as the cutoff. Okay. Class 3 is further divided as 3A, 3B, 3C. 3B is also called as A bar C because it has overlapping features. A is active lesions, C is chronic, active on chronic, C is class 3C is chronic lesions. Okay. Active lesions, the lesions are having proliferative activity at the time of biopsy. Chronic lesions, there is only some sclerosis and hyalinization, no activity is present at the time of biopsy. Chronic changes are there in the background, and on that super added active changes are there, we call it as B or A bar C, that is active on chronic. 3A, B, C. Just remember 3 is focal. Okay. Class 4 is diffuse lupus nephritis. This has more than 50% glomerular involvement. It shows subendothelial deposits mainly. Okay. This is seen in majority again. Class 4, 3 and 4 are the majority. 35 to 60% patients of SLE will show you class 3 and class 4. Any patient can have simultaneously 3 and 4 changes. Okay. Both changes can be present. Some areas 3 and some areas 4 changes. Some areas class 6, advanced stages. So, whichever is the advanced, we mentioned that. Okay. So, 6 can have background 3 and 4 changes also. Right. So, class 4 changes. There is diffuse involvement. The involvement within one glomerulus can be segmental or global. If it is segmental, that is part of the glomeruli is involved. Out of 100, some 70 glomeruli are involved. So, it becomes diffuse or focal. More than 50. 70 is more than 50. So, it becomes diffuse. Within one glomerulus, parts of the glomerular tuft are involved. So, that becomes, no. That is not focal. Focal is number of glomeruli. Within glomeruli, only parts of that tuft. This is glomerular tuft. Okay, this is glomerulus. Within that, this is the tuft, glomerular capillary tuft. This is afferent, this is efferent, right? Within this tuft, only this part is involved, this part is involved, this part is involved. This becomes segmental. The entire glomerulus is involved. Okay, the thickening is present throughout. It becomes global. Now, if you go on counting how many glomeruli are showing this, out of 100, 70 are showing this, it becomes diffuse. Only less than 50, some 30 are showing it, it becomes focal. Clear? So, here in type 4, which is diffuse, we divide it into 4S and 4G. S is segmental involvement, G is global involvement. Clear? Okay. Type 5 is membranous. That is, there is thickening, membranous thickening seen in 10 to 15% of patients. There is subepithelial deposits. There can be background 3 or 4 type class 3 or class 4 changes. Class 6 is advanced sclerotic, end stage SLE, end stage lupus nephritis. That is class 6, where there is global sclerosis. Okay, so 6 classes. Class 1, no changes. Class 6, advanced stage. Class 6 is advanced stage. That is, you are having total sclerosis. Class 1, no changes at all. In between, class 2, 3 and 4 and 5 are there. 2, 3, 4, 5. 2 is minimal proliferative changes are there. There is proliferation. There is increased cellularity in class 2. Okay. Class 3 is there is proliferation, but it is focal, less than 50% of the glomeruli. Class 4 is it is diffuse, more than 50% glomeruli are involved. It can be segmental or global. Okay. Class 5 is mainly membranous. It's not proliferative. It is membranous. 2, 3 and 4 are proliferative. There is proliferation. Okay. Minimal into good amount but less than 50%, that is focal in 3 and diffuse in class 4. Class 5 is membrane thickening and class 6 is advanced stage. This class 4, that is diffuse involvement, is called as Wireloop lesions. So, the question was Wireloop lesions, that is class 4 SLE. Okay. Mesangial deposits of monoclonal kappa or lambda light chains is indicative of mesangial-proliferative glomerulonephritis, focal and segmental glomerulosclerosis, Kimmel-Steele-Wilson lesions, amyloidosis. Mesangial-proliferative we divided into type 1 MPG, mesangial-proliferative, that is, it is proliferation of the mesangium, not the membrane, that was MPGN, membranoproliferative. This is mesangial-proliferative. Okay, there is proliferation of the mesangium, expansion of the mesangium. Focal and segmental glomerulosclerosis, we have seen it produces nephrotic syndrome. There is sclerosis or hyalinosis within the glomeruli focally, some of the glomeruli, and segmental involvement. Okay. Kimmel-Steele-Wilson lesions refers to sclerosis of the glomeruli seen in diabetes, secondary to diabetes. Diabetic nephropathy is characterized by Kimmel-Steele-Wilson lesion in glomeruli, and within the tubules there will be Armani-Epstein lesions. Armani-Epstein lesions. This is also an MCQ within the tubules. Tubules will show Armani-Epstein lesion. So, diabetic nephropathy will show these changes. Kimmel-Steele-Wilson lesions, which is nodular glomerulosclerosis, diffuse nodular glomerulosclerosis. There will be formation of nodules in the kidney. By sclerosis, formation of sclerosis will be there. That is called Kimmel-Steele-Wilson lesion. Then tubules will show Armani-Epstein lesion, which is nothing but vacuolization within the tubules. Then there will be papillary necrosis. Tips of the renal papillae will show necrosis. So, diabetic nephropathy is one of the causes for papillary necrosis. Papillary necrosis. I'll slightly deviate. Papillary necrosis, the 3 important causes for papillary necrosis are: one is NSAIDs, analgesic nephropathy, NSAIDs or analgesic nephropathy, amyloidosis, diabetes, and very rarely sickle cell disease. Sickle cell disease can also cause papillary necrosis. Mainly it's analgesic nephropathy. Okay. Please also remember diabetes and sickle cell disease. Okay, that is papillary necrosis. Those are all changes seen in diabetes. Kimmel-Steele-Wilson is one example. Here we are talking about deposition of kappa or lambda light chains. Light chains of immunoglobulins are deposited in which disease? In different organs, light chains of immunoglobulins get deposited in amyloidosis. Amyloidosis, secondary amyloidosis is characterized by deposition of amyloid immunoglobulins light chains, either kappa or lambda. That is called as light chain restriction, either kappa or lambda. They can get filtered in urine, and those proteins are called as Bence-Jones proteins. They appear when heating the urine at 50 to 60 degrees. When you heat the urine at temperature of 50 to 60, they will appear in the urine. They will precipitate. If you heat it further, they will get dissolved. They will disappear. And if you cool it, again bring it back to 50 to 60 degrees, again they will reappear. So that is the temperature when they are seen. What they contain? They contain either kappa or lambda light chains of immunoglobulins. Immunoglobulins have heavy chains and light chains. Heavy chains 5 types. In different IgG, IgM, IgA, IgE and IgD, there will be one type of heavy chain. Light chains only 2 types, kappa or lambda. One of them will be present, okay, in systemic amyloidosis. So that gets deposited within the mesangial. Okay. So answer here is amyloidosis. In renal disease, albumin is first to appear in urine. You already know this. We have discussed this. So please tell me. Albumin is first to appear in urine because of its high concentration in the plasma, has molecular weight slightly greater than molecules normally getting filtered, high albumin globulin ratio, tubular epithelial cells are sensitive to albumin. In renal disease, albumin, they are saying, see, concentrate on the question. In renal disease, albumin is first to appear. Normally it doesn't appear. Normal persons, it doesn't appear. Okay. So if the tubular epithelial cells are sensitive to albumin, normally it should appear. So it can't be option D. Option D ruled out. A, B, C. It appears in urine in renal disease because it is in high concentration. That doesn't mean anything to us. Whichever is high should come in the urine. No, that is not the rule. Okay. So first one is ruled out. Has high albumin globulin ratio. So it is same as A. C and A are same. They are talking about concentration of albumin. They are saying that albumin is the highest protein. Okay. In plasma. That's why it comes. That is not the logic. The logic is there is the molecular weight of albumin is slightly larger than the solutes which normally get filtered. Any change in the slit diaphragm will make albumin get filtered. In renal disease, there is a slight change in the slit diaphragm diameter. Okay. So answer should be B, that is has molecular weight slightly greater than molecules normally getting filtered. It's a low molecular weight protein, the lowest among all the 4. The molecular weight, it's slightly greater than normally filtered solutes. There are very small, rare solutes in the plasma. They can be drugs, they can be foreign substances which can get, they can be ions which can get filtered. Okay. Among the 4 plasma proteins, the lowest size is albumin, 59 kilodaltons, the lowest size. That is slightly larger than what are normally getting filtered. Normally so many things are getting filtered. Normally glucose gets filtered, normally urea gets filtered, normally ions get filtered, all these drugs get filtered, all these are uric acid gets filtered. They are all small, they are all very small. Plasma proteins are larger. Among the plasma proteins, the smallest is albumin, and that size is slightly larger than what can get filtered. If some change you bring about in the slit diaphragm, slightly increase, if it is this much, slightly make it this much, some increase, albumin will also get filtered. Globulins, fibrinogen, prothrombin are still larger. Even this slight increase cannot filter them. To filter globulin and all, you should totally create big holes within the basement membrane, which is not possible, right? Okay. So answer here is B. HIV associated nephropathy is a type of membranous, immunotactoid, collapsing, fibrillary. It's a type of collapsing glomerulopathy. It's called as collapsing glomerulopathy because there is collapse of glomerular tuft. It gets collapsed. Why? Because there is sclerosis. So it's a type of FSGS, focal segmental glomerulosclerosis. HIV associated nephropathy, it's called collapsing variant of FSGS. There is basically cystic dilatation of the tubules which are filled with the proteinaceous material. There is basically dilatation, cystic dilatation. The tubules undergo cystic dilatation with proteinaceous material. There is inflammation, fibrosis, and this HIV nephropathy is seen in 5 to 10% of HIV patients. 5 to 10% of HIV patients will have this. Basically, the lesions are called as tubuloreticular inclusions in the endothelial cells. Please remember, this has been asked as an MCQ option. It has been kept as an option. Tubuloreticular inclusions within the endothelial cells. Okay, but nowadays this incidence has come down because of effective antiretroviral therapy. The ART drugs are very, very effective these days. So the effect of HIV nephropathy has come down. Shall we move? So this is a picture which shows collapse. This is the glomerular tuft. My cursor is not moving. Raju sir. Okay. Okay. Right. So here you can see that there is collapse of the tufts. The tufts are getting collapsed. Okay. With the deposition of lot of proteinaceous material. This is called as collapsing glomerulopathy. Acute diffuse proliferative glomerulonephritis will have all the following features except which one we are talking about. Please read the question carefully first. We are talking about acute diffuse proliferative glomerulonephritis. What is that? Which entity? Nephritic. Yes, of course, nephritic. But which entity? What was the cause? What was the etiology? Post streptococcal, the first entity which we discussed. PSGN, post streptococcal glomerulonephritis. We said has many synonyms: acute, diffuse proliferative, endocapillary. All these are synonyms for that. Okay, that will present with nephritic manifestations. So it will have, nephritic will have all these features except microscopic hematuria, raised blood urea levels, raised serum creatinine levels, hypoalbuminemia. Okay, it will have all the following features except which one? It will not have hypoalbuminemia, because in nephritic syndrome proteinuria is mild proteinuria is there. So that will not cause hypoalbuminemia. Hypoalbuminemia is seen with massive proteinuria, which is seen in nephrotic syndrome. Nephritic will have mild proteinuria, mild hematuria, and mild compromise in the renal function. Oliguria is there. Oliguria means there is compromise in renal function. If renal function gets compromised, there will be azotemia. What is azotemia? Azotemia is biochemical changes because of renal compromise. That is increased BUN, blood urea nitrogen, increased urea, increased creatinine. So raised blood urea level, raised creatinine level. All these are called as azotemia. When the changes are present only at biochemical level, we call it as azotemia. When biochemical plus clinical features are there, clinical manifestations are there, oliguria is there, patient is becoming anemic, patient has renal osteodystrophy, all these clinical features are there, we call it as uremia. So what is the difference between these two terms, azotemia and uremia? Azotemia is biochemical, just biochemical. You send the sample, blood sample for test to the laboratory, the results comes and you see BUN is elevated, BUN is blood urea nitrogen, BUN is elevated, creatinine is elevated, urea is elevated. Patient is alright, patient is completely fine. It is azotemia. Patient has symptoms plus biochemical parameters, it is uremia. Okay, so these patients are azotemic. So there will be raised urea, raised creatinine, hematuria will be definitely present, but they will not have hypoalbuminemia because there is no massive proteinuria. But still they will have edema because of sodium and water retention. Excellent. Okay. Collapsing glomerulopathy, again repeat MCQ from the same topic, but the question is slightly different. Collapsing glomerulopathy features are tuft necrosis, mesangiolysis, parietal epithelial proliferation, hypertrophy and necrosis of the visceral epithelial cells. Okay, there is collapse of the tuft. Tuft is collapsed, but not because of necrosis. There is slight twist here. They have tried to play around with the words. The tuft undergoes collapse, but not because of necrosis. That undergoes collapse because of fibrosis. Why is the fibrosis? The fibrosis is because of necrosis of visceral epithelial cells and secondary hypertrophy. The visceral epithelial cells undergo necrosis, so there will be a lot of proteinaceous material. They are characterized by hypertrophy of the remaining. Okay, so let us see collapsing glomerulopathy in slight detail now. Where is the duster? Okay, the collapsing glomerulopathy has a necrosis of the visceral epithelial cells. These are the visceral epithelial cells which undergo necrosis. Okay, if some of them undergo necrosis, the others will have to undergo hypertrophy. Some are lost, so others have to undergo hypertrophy. At the place of this necrosis, there will be deposition of proteinaceous material, pink material. No blue is there, no nucleus is there. Okay, pink material is there. As a result, this will incite secondary fibrosis of the tuft. Tuft fibrosis, please understand the words, tuft fibrosis, visceral epithelial necrosis, remaining visceral and epithelial cells undergo hypertrophy, deposition of proteinaceous material. So put all of that together, what are the findings here? Tuft necrosis. No, tuft doesn't undergo necrosis. It undergoes only collapse because of fibrosis. Mesangiolysis. Mesangium is not at all involved. Parietal epithelial proliferation. Parietal epithelial cells not at all involved. Parietal epithelial cells involved only in crescentic glomerulonephritis, that is RPGN, rapidly progressive glomerulonephritis, which is also called crescentic. There the parietal epithelium will get involved. This is the Bowman's space, okay. This is the glomerular tuft. This is visceral epithelial. This is parietal epithelial. In between is the Bowman space. That Bowman space continues as the urinary tubule, right? As the PCT first and then loop of Henle, all that, right? So this between this Bowman space on either side is visceral and parietal epithelium. Parietal epithelium is involved only in crescentic glomerulonephritis, that is RPGN. In rest all visceral is involved. So we are left with only option D, which is hypertrophy and necrosis of visceral epithelial cells. That is the hallmark feature of a collapsing glomerulopathy. The prognosis of rapidly progressive glomerulonephritis, that is crescentic glomerulonephritis, depends on, we know that RPGN is characterized by crescent formation. Prognosis is going to depend upon the number of the crescent, size of the crescent, shape of the crescent, cellularity of the crescent. All these four important features, four features are important determinants of the crescents. Crescents can have variable shape, but generally they are like half moon shape. They are like half moon shape. They are like this, okay. Then the cellularity is going to be determined by different cells in crescentic glomerulonephritis, but the main cells are parietal epithelial cells. Parietal epithelial cells are the ones which proliferate. Apart from them, there can be leukocytes, there can be endothelial cells and visceral epithelial, all these can contribute, but the main cells are parietal epithelial cells. And the main stimulant, all these are MCQs, please remember all these are MCQs what I am telling. The main stimulant for the parietal epithelial cells to proliferate is fibrin. Fibrin gets escaped, it enters here, fibrin comes here from the plasma. This is tuft, this is glomerular tuft, the capillary tuft. From this the fibrin will come. Fibrin will stimulate these parietal epithelial cells, they will divide. The other cells, that is leukocytes and all, they will also contribute, and finally you get a crescent here like this. Crescent means half moon shaped. The edges are small, okay. The center is thick. We call it as Eid ka chand. It looks like that, okay. Crescent shape. That is crescent. Prognosis is not going to depend on shape of the crescent, whatever is the shape, because the commonest shape is half moon. The size of the crescent, size is most of the times fixed. It is large only. Cellularity also. Cellularity is going to come from parietal. It is how many glomeruli show crescent formation. How many? Whether plenty of glomeruli are going to show crescent formation, the prognosis is bad. Very few glomeruli show crescent formation, prognosis is good. So it is the number of crescents which is going to determine the prognosis of RPGN or crescentic glomerulonephritis. Which type of FSGS has worst prognosis? We saw different types of FSGS. Okay, collapsing variant we have seen in detail. Apart from collapsing variant, there is one variant called as tip variant, which involves only the tips of the glomerular capillary tuft. Perihilar variant, which involves the hilum of the glomerulus, where the afferent comes and efferent leaves, no, that part is called as hilum. Only that portion is involved, perihilar variant. There is one variant which is called NOS, not otherwise specified. Neither hilar, nor tip, nor collapsing, nothing is there. NOS, okay. So out of this, which has worst prognosis? So the one which we have been discussing in detail, that is the collapsing variant, has the worst prognosis. The best prognosis is for the tip variant, and the most common variant is not otherwise specified. Please remember, all three are MCQs. The most common type of FSGS is not otherwise specified. Not otherwise specified, that is no special feature, okay. Best prognosis is tip variant, worst prognosis is collapsing variant, okay. Pauci immune glomerulonephritis is seen in Pauci immune. Pauci immune, we said, is a type of RPGN, type 3 RPGN, excellent. We divided RPGN into type 1, type 2, type 3. Type 1 we said is good pasture disease, type 2 we said is PSGN like, it is same as PSGN. Type 3 there is no antigen antibody complex formation. So that's why it's called Pauci immune. So in Pauci immune, when there is no antigen antibody complex, it has been blamed to cytotoxic T lymphocytes. It has been blamed on cytotoxic T lymphocytes. So they can be seen following vascular diseases, mainly vasculitis syndromes, collagen vascular diseases. Of these, which is the one which has maximum vasculitis component involving small capillaries? Microscopic polyangiitis. It is same as polyarteritis nodosa, PAN, but PAN involves medium-sized vessels. This involves small capillaries, microscopic polyangiitis. There you can find Pauci immune glomerulonephritis secondarily. So answer is microscopic polyangiitis. Okay. In Wegeners granulomatosis, characteristic feature seen is, we are talking about the secondary manifestations of Wegeners granulomatosis. Wegeners granulomatosis, you know, is a vasculitis syndrome that is going to involve the vessel walls, medium-sized vessel walls, and it is characterized by necrosis. The hallmark feature in Wegeners granulomatosis is necrosis. It can involve so many organs secondarily. Most important among them is kidney. So there can be glomerulonephritis in Wegeners granulomatosis. And in kidney also it is going to produce the same hallmark feature, that is necrosis. So you are going to find necrotizing glomerulonephritis, which doesn't involve the entire kidney. It involves only the parts of the kidney. That's why it becomes focal necrotizing glomerulonephritis. In kidney vessel wall, you do not find granulomas. Granulomas in vessel wall is a feature of two important types of vasculitis syndromes that involve the bigger vessels. One involves these vessels at the temporal, giant cell arteritis, also called temporal arteritis because it involves temporal. And one very closely involved disease that is very close to it is Takayasus, which involves larger vessels, but the age group is less than 50. In giant cell arteritis, the age group is more than 50. That's the hallmark feature. Otherwise, both of them have same involvement. Okay. In them, you are going to find granulomas. Nodular glomerulosclerosis, we already discussed, is a feature of nodule formation. Nodule formation in the kidney. There is kidney, entire kidney has big nodules. We called it as Kimmel-Steele-Wilson lesion. Diabetic glomerulosclerosis is also called as nodular. Interstitial granulomas. Interstitial granulomas can rarely be seen in midline lethal granulomas. Midline lethal granulomas, which is a type of malignant lymphoma. There you are going to find interstitial granulomas. So we are, by exclusion, we are left with only one, focal necrotizing glomerulonephritis, which we already have discussed is a feature of Wegeners granulomatosis. Okay. True about fibronectin nephropathy are all except, all the following are true, only one is wrong. Which is the one that is wrong? Autosomal recessive inheritance pattern, glomerular enlargement and pass positive trichrome positive mesangial deposits. Glomerulus do not consistently stain for immunoglobulin and complement. Ultrastructural feature is presence of large electron dense mesangial or subendothelial deposits. Okay. Now, fibronectin nephropathy is a special type of nephropathy where a molecule which is present in the basement membranes and ground matrix, ground substance of the intercellular matrix called fibronectin gets deposited in the glomeruli. This generally does not elicit an antigen antibody reaction. So you are not going to find a lot of immune complexes which stain for immunoglobulins or complement activation. So they do not stain for immunoglobulin or complement. So that is a correct statement. They consistently do not stain because they generally do not elicit lot of immunoglobulin or immune complex mediated reaction. Complement activation is not a characteristic feature. Okay. They sometimes have deposits, electron dense deposits, but they are not rich in immune complexes. In the mesangium, mesangial deposits are very common in this fibronectin nephropathy. Okay, so that also becomes a correct statement. And if you stain these material with special stains, they are positive with PAS, that is per iodic acid Schiff stain. They are positive. They appear pink globules within the mesangium. If you see the mesangium of the glomerulus, there are pink globules, PAS positive material. They contain a lot of collagen. So they also stain positive with trichrome stain. So here we are learning in this question about two special stains. One is called PAS, the second one is called as trichrome. PAS is a stain meant for polysaccharide substances. Polysaccharides, wherever free aldehyde groups are there, those substances will stain for pus. So which are the substances, can you tell me, which are going to stain with pus? Okay, carbohydrates, polysaccharides, especially starch, glycogen is going to stain. Okay, mannose, of course, sometimes. Apart from that, fungal cell walls, fungal hyphae, fungus is going to stain for pus. Storage material in any storage disorders like Gaucher's disease, Niemann-Pick's disease, all these are going to be lysosomal storage disorders, LSDs. All these are going to be pus positive material. Okay, mucin is pus positive material. So wherever there is mucin deposition, okay, mucinous carcinomas, mucin in so many tumors, mucinous cystadenomas of ovary, all these are pus positive. So wherever pus is stained, it gives pink color to the substance. Those substances are called as pus positive. We are going to divide pus positive substances into two categories: pus positive diastase resistant, pus positive diastase sensitive. Okay, so pus will be followed by, whenever we are doing pus stain, and a pre-digestion with diastase enzyme is done. Diastase is an enzyme that splits, that divides polysaccharides. Okay, it cuts the polysaccharide. Okay, before we stain it with pus, a pre-digestion, before staining, a pre-digestion with diastase is done. The tissue is taken, it is put in diastase, and then it is stained with pus. After pre-digestion, if it still stains, takes a pus stain, it is called as pus positive diastase resistant. It is resistant to diastase. If it doesn't stain, it is called as pus positive diastase sensitive. There is only one material that is sensitive, that is glycogen, because diastase is going to cut the glycogen. Diastase enzyme is going to cut the double bonds between the monosaccharide units in the glycogen. Okay, there is extensive 1,4 cross-linking in glycogen. All that is broken down by diastase, so it doesn't take up pus stain. There are no free aldehyde groups. Okay, it doesn't take up. So it is the only pus positive glycogen sensitive material. All other pus positive material are diastase resistant. Okay, so here also in fibronectin nephropathy we are having pus positive material, and it is fibronectin, it is not glycogen, so it has to be diastase resistant. Glycogen is the only one which is diastase sensitive. Okay, it is also positive for another special stain which we are learning in this question, that is trichrome. The best example is Mason's trichrome, MTS, Mason's trichrome, which is a connective tissue stain. The name is trichrome. Chrome means color, tri means 3. There are 3 colors. It takes up 3 colors. Okay, collagen takes up blue color, muscle takes up red color, and nuclei take up violet color. Collagen takes up blue color, muscle takes up red color, and nuclei take up violet color. Those are the 3 colors. That's why it's called trichrome. It is used mainly to identify collagen. Okay, so wherever there is fibrosis, wherever there is deposition of fibrotic material, collagen is deposited, we are using this MTS. So in fibronectin nephropathy, it is pus positive diastase resistant material, and it is MTS, that is Mason's trichrome stain positive material. It doesn't show consistent staining for immunoglobulins and complement. It has mesangial deposits mainly, and the disease runs in autosomal dominant fashion. Okay, so all the options are correct here except one, that is first one which says autosomal recessive. So it runs in an autosomal dominant fashion. So fibronectin nephropathy, I have covered it in detail because this is a hot topic. I think they are going to again repeat this question in 1 or 2 years now in AIIMS, fibronectin nephropathy. Okay, is it the repetition of the same thing? Yeah, same question is repeated, that is Wegeners granulomatosis, we have focal necrotizing glomerulonephritis. Now look at this question, a big history is given. A 7-year-old girl is brought with complaints of generalized swelling of the body. Urinary examination is going to reveal grade 3 proteinuria and the presence of hyaline and fatty cast. She has no history of hematuria. Which of the following statements about her condition is true? We'll look at the options later. First, analyze the question. It's a child. It's a child, right? The history is child. The child has generalized swelling, edema of the body, generalized edema. Okay, anasarca it's called, generalized edema, anasarca. So to produce that generalized edema, the cause should be either there is severe hypoalbuminemia or there is sodium and water retention. Sodium and water retention generally causes mild edema, that too around the orbits, wherever there is loose tissue, periorbital, fluffy areas, or dependent areas like lower extremities, around the lower extremities, bilateral pitting type of pedal edema, or periorbital, looser tissues. Sodium and water retention. Hypoalbuminemia generally causes massive edema and it involves all the tissues of the body. To begin with, it might be just periorbital and pedal edema, but later on it involves the entire body. Okay, so generalized is a clue towards there is hypoalbuminemia. Okay, second clue, child with hypoalbuminemia. Third thing is there is grade 3 proteinuria. Proteinuria we grade it as mild, moderate, massive, grade 1, grade 2, grade 3. So grade 3, massive proteinuria. So that explains our hypoalbuminemia. Massive proteinuria, hypoalbuminemia, and generalized edema. Okay, there is presence of fatty casts. Now we are finally arriving at the syndrome, that is, it is nephrotic syndrome. There is massive proteinuria, there is hypoalbuminemia, generalized edema. Because of that, in a child, presence of lipiduria causing fatty casts. Okay, so this is a child presenting with nephrotic syndrome. And in children, the commonest cause of nephrotic syndrome is minimal change disease. Okay. So, minimal change disease, which are the following facts are correct. No IgG or C3 deposition. Her C3 levels will be low. C3 levels will be low only if there is C3 deposition in the glomeruli. Glomeruli, C3 is deposited. So, in the blood, C3 levels have to be low. That is called as hypocomplementemia. Whenever C3 gets deposited in the glomeruli, in the serum, C3 level will fall. Hypocomplementemia will be present. So, her C3 levels is low means they are trying to say that C3 is deposited in the glomeruli. In minimal change disease, there is no C3 deposition in the glomeruli. IgA nephropathy is the likely diagnosis. IgA nephropathy patients generally present as recurrent hematuria. We have discussed this. They present as recurrent hematuria. One episode of hematuria this month, again next month one more episode which gets cleared off on its own. Okay, the mother always gives a history. You might be wondering, what if the mother brings the child to in the first episode itself? The hematuria has begun and first episode itself she has brought the child. Definitely hematuria is a concern for any mother. So she'll bring. So that time we definitely think of IgA nephropathy, but we do not confirm the diagnosis. We put the patient on mild steroids, it gets cleared off and again it repeats back. When it repeats back, our suspicion of IgA becomes stronger, IgA nephropathy. And then deposition of immunoglobulin A, especially in the mesangium on renal biopsy, is going to clinch the diagnosis. So it's not IgA nephropathy. Alport syndrome is the likely. Alport syndromes can present as nephrotic syndrome. We said all the three hereditary nephritis, that is Alport's, Fabry's and nail patella, generally present as nephrotic or sometimes rarely as nephritis. They can present as nephrotic, but they are not very common. The most common is MCD. So MCD is characterized by no deposits. So we'll go for option A, that is no deposits of immunoglobulin. A person with radiologically confirmed reflux nephropathy develops nephritic range proteinuria. Which of the following would be the most likely histological finding in this patient? Okay, reflux nephropathy is going to produce what type of manifestations? It's very simple. Patients having reflux nephropathy, there is vesico-ureteric reflux between the kidney and the ureter, or reflux at the pelvi-ureteric junction because of either presence of valves or presence of decreased tone. The intravesicular part of the ureter, the part of the ureter that passes through the bladder, that is called as intravesical portion, that has to get obliterated whenever there is micturition. Whenever the bladder is contracting, the detrusor muscle of the bladder is contracting forcefully, the part of the ureter that passes through the bladder is closed forcibly. That's why there is no reflux. But sometimes there is no intravesical part only. The intravesicular part is very small and it doesn't get closed. As a result, there is reflux. This reflux is going to continuously increase the pressure in the pelvic calyceal system and as such within the uriniferous tubule, and that pressure gets transmitted back to the glomeruli. Back pressure from the ureter to the pelvic calyceal system, from the pelvic calyceal system to individual nephrons, and within the individual nephrons it goes to the glomerular tuft. That back pressure is going to continuously cause thickening of the membrane and sometimes FSGS. Both changes are seen. Of these, the most consistent change is FSGS. So, patients of reflux nephropathy will have sclerosis because of that continuous pressure. That continuous pressure is going to cause sclerosis. But that pressure is not uniform throughout. So, it is only in some segments of the tuft and only in some of the glomeruli. So, it is going to be focal and segmental glomerulosclerosis, okay, FSGS. Second change is membranous, can also be seen. Both are there in the option, but the best is FSGS. The best constant, consistent change is FSGS. We will go for FSGS. Mutations in collagen 4, type 4, A5 chain. We have already seen A3. Where we have seen A3? Good pasture. We have already seen A3 in good pasture. That time we said A5 is going to be seen in Alport. So here answer is Alports, which is a type of hereditary nephritis. Most common nephropathy associated with malignancy, secondary malignancy, membranous, MCD, IgA, FSGS. Okay, two of these are seen with malignancy. FSGS is also seen in malignancy and membranous is also seen. Likewise, like how we saw with the reflux also both were there. Membranous was also there, FSGS was also there. But reflux more commonly caused FSGS, malignancy is more commonly caused membranous glomerulonephropathy. Okay, so please remember that it commonly causes membranous.